Okay, it seems to be slowing down, so we're going to go ahead and get started. Hello, everyone. Thank you for joining us on what I know is a very busy time of the year for everybody. Just so you know, you're in the right place. This is Pharmacy Access Office Hours. You've obviously figured out at 2 o'clock. There was a typo in this week's NAC email update saying 3 o'clock, but nothing's changed. We're going to keep staying at 2 o'clock. Today's focus topic is sliding fee and contract pharmacy. So a couple logistics here. Please dial in by your phone, and you can also find the handouts on NoddlePad and on NAC's webpage. So usual format, we're going to start with some operational updates. Then our focus topic is Jim Donnelly from Hudson Headwaters is going to talk about how his health center implements a sliding fee scale in contract pharmacies. There's actually a Q&A, I forgot to list it here, about an email people are getting from Walgreens right now that's adding a little bit of confusion. And once again, in case you're new to this, please know we've got a lot of experts with a lot of different types of expertise on the line. So please go ahead and have comments, conversations about any pharmacy-related topic over in the chat box. Take advantage of everybody who's here. So on operational updates, you got me from NAC. I'm going to start with just an environmental scan. These webinars are about increasing access to pharmaceuticals, and there was a Gallup poll that just came out a couple weeks ago. It said that in January, 19% of adults reported difficulty affording their medications. That went up to 23% just in the 10 months from January to November. So clearly the work we're doing is meeting a very real need out there in the field. Another thing with in terms of Congress, there has been obviously a lot of discussion this year about drug pricing. It looks like Congress is basically giving itself a reprieve on that. They've given up any hope of getting anything passed this year, obviously. And when they pushed back the funding for a whole bunch of health extenders, including Section 330 and the National Health Service Corps and dish hospital cuts and other things, they also said, okay, we'll give them funding through May 22nd, and then between now and then we'll figure out what we're doing on drug pricing and surprise billing. And the expectation is that those bills, those proposals, once finalized, will provide the funding to support the activities like Section 330 and the dish cuts to hospitals, et cetera. So in other words, no decisions this year, and things are going to just drag on into next year. One piece of news that was positive, the Senate Finance Committee released, I believe, last week a revised version of its drug pricing bill. And in there, they had recently added some language around DIR fees. Now, it's specific to Medicare Part D, but their proposal said that DIR fees and any other quote-unquote pharmacy price concessions would need to be billed to the pharmacy upfront, no more after the fact, find out 6 months later what and how much the fees were. Obviously, a long way to go from something that the Finance Committee has proposed to something that is law, but it was still a pretty big step forward because the first version of the bill did not include that. One other environmental thing, HRSA. Just want to make sure people know that they are back at their usual business of conducting 340B audits. There seemed to have been a little halt there for a while or slowdown, but it's back to normal. In terms of, and one other thing I wanted to mention is that we have gotten clear guidance in writing or electrons from BPHC about where contract pharmacies go on Form 5B. And they have said explicitly contract pharmacies go in column 2. Now, we're talking about the typical contract pharmacy arrangement here where, you send the patient out, the contract pharmacy receives the 340B drugs, then they send part of the payment back to you, et cetera. There are the occasional, like just referral arrangements where a health center doesn't actually get involved in any of the payment. That's a different story, but the typical contract pharmacy situation we talk about in 340B, HRSA has been clear that that goes in Part 2. in column 2. If you want to keep the OSV reviewers happy, put it in column 2. I know there are reasons why people might argue that that's not really a perfect fit, and I get that, but if our goal is to keep the OSV reviewers happy and you have a typical contract pharmacy arrangement, I recommend that you put it there. Moving on, one other important development this week in the environmental drug space. Yesterday, HHS released a proposed regulation that would allow for the importation of drugs from Canada. There's actually been a law in the books for this to allow this for years, but nobody's done anything about it. Well, now they're trying to move forward on that. So there's a new type of section something plan that we all have to learn. This is going to be the Section 804 plan. A Section 804 plan is a plan that you would submit here. Let me see if I can mute everybody here. Mute all. Mute all. Huh, that did not seem to work. Tim, can you try to mute everybody? Hopefully that worked. Thank you. No, it did not. Are other people getting the same feedback I am? Hey, Tim, There, that sounds better. Thank you. Okay. So anyway, all that's been released so far is a proposed regulation. It says the drugs could be imported from Canada, no other countries, and that in order to get permission from the feds to do this, you not only have to demonstrate safety, that the drugs would be safe to the American public, but also, quote unquote, significant savings to consumers. So like many other things, there's a ways between where we are right now and when the first imported drug officially comes in from Canada. But unlike, say, what's going on with DIR fees, there's already action moving forward to put this in place. 4 different states have passed laws to allow them to do that, and 2 have already sent concept papers to HHS. So we may see something coming out of this in the relatively near future, at least compared to some other things. Moving on to PrEP Truvada. You've all probably heard that Gilead has donated 11 years worth of Truvada for 200,000 patients. They donated it to the federal government. The federal government, what I've heard kind of unofficially, was very excited to get it, but is struggling a little bit to figure out how to actually get it out into the hands of individuals who would qualify for it. And to qualify, a person would need to be uninsured and HIV negative. So just wanted to let you know that NAC and Tim, Millette, and I are working with Direct Relief to propose a distribution channel to try to get that free PrEP directly to health centers. Because what the press has been saying so far is that it would all go directly to like a CVS or a Walgreens, and we don't want to have to send our patients out. If our patients need that, we want to be able to get that free drug right in the health center or through our existing distribution channels, not to have to be forced to go out to a chain pharmacy. So keep in touch, but looks like we're going to have a meeting with the department very soon on that. So I'll let you know how that goes. Couple operational things from the HRSA perspective. The registration window for new sites and new contract pharmacies is coming up right after, it starts on the holidays. So time to make sure you get all that paperwork done before you head out. But please remember, only use those extended registration windows, the ones that start after January 15th. Only use them if you absolutely have to. Please, if you have a site that you want to register, get ready to do it in this 2-week window. And also, if you are registering a contract pharmacy, there is a heightened level of oversight on registrations for contract pharmacies relative to what there was a year ago. So you can go back and look at that slide, but you need to make sure that your contract itself is in order. HRSA may ask you to submit it before they approve your registration. Also, it's this lovely time of the year again, is coming up soon. 340B recertification is coming up. This is the annual time when health centers are required to attest to HRSA that all of their information in the 340B database is up to date and accurate, and that they are in compliance with all of the requirements for 340B. The window to do that opens in late January closes in late February. But remember, if you don't do that, if you don't complete recertification in time, you will be out of the 340B program for at least 90 days. There it goes. Okay, a couple of learning opportunities to put on your calendar. First of all, office hours next month. The focus topic is going to be direct relief, which is a nonprofit humanitarian organization based out of California. I will confess that I've known for 10 years that direct relief worked with health centers, but up until this week, I thought all they did basically was that they were limited to emergency response stuff. I learned this week that they work with over half of the health center, just about half of the health center organizations in the country. They also work with 150 different drug manufacturers to get donated drugs, and then they distribute them out to health centers and free clinics. They also have systems in place to assist health centers in managing and taking full advantage of patient assistance programs. A lot of other stuff that is provided free to health centers, and they are eager and willing to work with more health centers. That's their mission. And so we're going to give them a chance to talk about what they have to offer to health centers so that if you're not familiar with them or you're only involved in some of their programs, you can find out about some other opportunities. Most of what they do, though, I found out, is pharmaceuticals, and they work all over the country. The 340B Coalition Conference is coming up in early February out in San Diego. We got another session set aside just for health centers, so there will be 4 of them. Thank you to Sue Vera, who has diligently put together all of the sessions. There's ones on reimbursement, and Sue, what are the other ones? She might be on mute. I'll ask her to put it in the chat box.
I just unmuted, Colleen.
Okay.
The first 2 sessions, other than your roundtable that is generally updates, the first 2 sessions are on bringing pharmacy into the fold, or really looking at integrating pharmacy as a core component of the medical home and how we can use pharmacy and use that to optimize the value of our pharmacy programs. There will be a part 1 and part 2 on that.
Great. Great, okay. And then if you can't make it all the way out to San Diego, which is understandable, for our February office hours, we're going to give, obviously, a very high-level overview of the FQHC-specific stuff that came out of that conference. And we'll make sure to make the slides available and stuff like that. But we know a lot of people want to be able to get to that conference and for one reason or another can't. So wanted to alert you to that. And finally, you may have seen that the schedule for the NAC PNI is very different this year from past years. We're at the end of, no, we're at the beginning of the week instead of the end of the week, all this stuff. At any rate, this has given us the opportunity to add another 340B university from Apexis. Thank you very much, Apexis. It's a 340B university designed specifically for health centers. Going to be in Washington, D.C. on Sunday, March 15th, right before the start of the PNI, the day before the PNI starts. I don't know the specific hotel, but I do know that they've signed the paperwork, so this is a done deal. Remember, it's a full day all about 340B taught by your health center peers and the HRSA-blessed experts at Apexis. So I encourage you to take advantage of that and mark your calendars now. Okay, you've probably seen this before, but please do take 1 minute to do the evaluation. And I know I've been saying this for months, but those evaluations really did come in handy. NAC just completed its application for the training and TA cooperative agreement for that competition, and I was able to show how the data on how valuable people find these office hours and parlay that into a larger piece of the next cooperative agreement. So thank you to everyone who's done these in the past, and I ask you to continue doing them because they really do help justify our increased focus on pharmacy. Finally, okay, that's it for pure operational updates. I'm going to tweak the formatting a little bit this time because before I turn the podium over to Jim, I want to give people some basic background on what clarification we have about sliding fee scale, charges, contract pharmacies, in-house pharmacies, et cetera, because there's a lot of questions out there in the field. And I want to highlight that along with these slides, wherever you found them, there is an excerpt from the NAC 340B manual, that talks specifically about charges, and it gets into a lot of the details that we won't have time to get into today. So please download that if you're interested. Okay, so charges and access to pharmaceuticals. First of all, the 340B program itself does not have any explicit requirements about how much patients should be charged for pharmaceuticals. This is one of the complaints you'll hear people who aren't supportive of this program make. They'll claim that some 340B provider is getting the drug for a really low rate and charging through the roof. And there is, in fairness, no requirement in 340B that prevents that. However, no explicit requirement. However, when health centers go to set their drug charges for their uninsured and underinsured low-income patients, the ones we normally think of as our sliding fee scale patients, there are three important things you've got to consider. And I'll go through those three, but the bottom line is that when you set your charges, it's a delicate balancing act between the responsibility to maximize affordability for the patient, to try to make it as affordable as possible, while also ensuring that that the health center can remain financially viable. So of the three factors you need to pay attention to, the first one is BIPIC and the sliding fee scale rules. And there's something here I think it's extremely important when we talk about BIPIC's requirements to distinguish between the letter of the law and the spirit of the law, okay? And oops, there's a call right now. Okay, between the letter of the law and the spirit of the law. I'm going to start with what BIPIC sliding fee scale requirements are around drugs. The sliding fee scale requirements, if you leave the compliance manual closely, says that sliding fee scale applies to services but not supplies. Thus, when we're talking about drugs, sliding fee scale applies to the professional dispensing fee if you have one and you're not required to have one. But it does not explicitly apply to the ingredient cost itself, okay? And BIPIC people have explained to me that this policy allows for the flexibility that they think is important to deal with the fact that prices change so quickly with drugs, and like how do you discount a penny price drug? How do you do a 4-level discount on a penny price drug? The fact that there are different arrangements between what you can probably do in-house and what you can get through a contract pharmacy, that flexibility allows so that there's not super rigid rules around, given all those things that are going on in the marketplace, okay? But, and this is really important, that does not remove health centers' responsibility to ensure that charges for drugs do not pose a financial barrier for sliding fee scale eligible patients. And just in case you're wondering where that responsibility comes from two places. Number one, congressional intent behind 340B, the language about the purpose of this program, to stretch scarce federal resources, et cetera. And the other thing is the health center mission. That's what we're here about, to help people get the health care that they need. So the bottom line is that, in summary, health centers should ensure that charges to sliding fee scale eligible patients charges for drugs do not pose a financial barrier. That does not mean that every single tiny, like maybe you have a different fee at a contract pharmacy than you have at an in-house pharmacy. That's that's addressed in the handout. As long as the person has access to the in-house pharmacy, then that can be allowable. There's different things you could do around the PDF, but the important thing to keep in mind here is that the principle, the spirit of the law, is to do what we can around affordability. So with that, and I'm sure there's going to be a lot of questions in the chat box, I'm going to turn it over to Jim to talk about how Hudson Headwaters implements a sliding fee scale in its contract pharmacies. And I have to tell you that Jim was one of the very first people I met when I started at NAC. He has taught me 98% of what I know about contract pharmacies. and probably 100% of what I know correctly about contract pharmacies. And he has been an invaluable help to me and to NAC in general behind the scenes for all the time I've been here in helping to understand this program. So many, many thanks to Jim for that in the past. And just give me a minute here and I will turn the slide thingy over to you. Okay, Jim, you should be able to move the slides now. Can you do it? Yes. Jim, you there? I can't hear you right now.
Can you hear me now, Kelly?
Yes, that's perfect. Thank you.
Okay. All right. I don't see my slides at this point. They were up.
You don't see them at all?
No,
okay. They're up on mine, no matter what you do. Okay, let me try to share them another way.
Okay.
You want to go ahead and get started while I figure this out?
Sure, I'll do an intro. Well, first of all, thank you very much for the nice introduction. I really do appreciate sharing what we do, but the intent here is to share one application of how we are successfully offering sliding fee discounts across multiple contract pharmacies across a very wide geographic region for our health centers and our health center patients. I know that all health centers are different. Our payer mix may be vastly different than your health centers. You know, and like I said, if you can pick up anything from what we do and apply it and customize it and come up with a mechanism that you think would work for your health center, that's the intent of this presentation. So what I'm going to talk about today are who we are as Hudson Headwaters Health Network, the network that I work for. We'll talk about sliding fee and how we approached it and the early decisions that we made. I've been here since 2002, and we wanted to make sure that we could apply a sliding fee program that was going to work as I do see the slides now, Colleen.
Great. Now I can't see them, but you go ahead if you've got them. Okay.
I just want to make sure I can advance them, that's all.
Yeah.
Okay. Let me just see if I can move that down. Well, we're going to have to see what happens with the advancing of the slides.
Okay.
Can everyone else see the slides? If they want to put a message in the chat box. Currently the slide that I see is, okay, Sue says she can see them. This is me. I'm Jim Donnelly. I'm the Executive Vice President of 340B Specific Pharmacy Services at Hudson Headwaters Health Network. And as I mentioned, I joined the network back in 2002, and it has been a growth process for our health center. Back then, we were, I guess, given the authority of having the first in the nation alternative method demonstration project to contract with multiple pharmacies. And in doing that, we started off with no contract pharmacies, but knew that we were going to have to contract and convince pharmacies that they could do 340B with us. At the same time, we wanted to make sure we had access to our sliding fee program at these pharmacies. So we made some early decisions, and that's where I'm going to start with this presentation as soon as I can get the slides to cooperate. So bear with me. And here's today's objective. So whoever's advancing the slides, I appreciate that, and we can do the old Crimp method. I can deep, and we can move them forward.
That might be what we have to do here. Okay.
Yeah, sorry about that.
No problem.
So I'm going to stress again, it's one successful sliding fee model program that it does work very well across multiple contract pharmacies. So as we grew into multiple pharmacies, the early decisions that we made proved to be very, very advantageous for making sure that we could keep control of our program and offer a consistent experience for our patients across all the different various models that we were going to get involved with down the road. We also wanted to make sure that we could balance the 330 grantee requirements, as Colleen mentioned earlier. We wanted to keep control and use multiple contract pharmacies. And how do we do that effectively? The method that I'll talk about that works well for us is to use a pharmacy benefits manager or a PBM. And I know, as Colleen and I talked in the past, you think, some people think that that might be a four-letter word, but the nice thing about using a PBM is that it integrates into a retail pharmacy situation very, very well. And that's the part that I want to make sure that we talk about. And if that delivery mechanism can work for anyone else, regardless of the slide tiers that you come up with and your board has approved, then that's something that might be a good takeaway for others if they try to implement across multiple retail pharmacies. Let's advance from here. So let me give you a little background on who we are. We are a network of 18 and now 19 health center sites in a very rural part of upstate New York. And when I say rural, we'll show you the map, but this is an area that's really the right half of the eastern half of the Adirondack Park. So we start with a small city of Glens Falls in the southern part of our service area, and we go up to the Canadian border. And some of those small towns have no pharmacy option of their own. They don't have really much else of their own, and the patients travel throughout our service area. So the difficulty that we had early on was we couldn't abide by the restriction of having one pharmacy per health center site or one pharmacy for our patients to access per healthcare delivery site, as was the restriction early on. We wanted to make sure that our patients could go to any pharmacy that we were going to be able to contract with as we grew our program. And that's why our alternative method program, our alternative method project was approved. So we currently serve 80,000 patients annually, 360,000 patient encounters annually, and we employ over 800 people in this very rural area of upstate New York. So the geographic area is 5,600 square miles. So in real terms, if you took the state of Connecticut and measured the square miles, it would be about the same geographic surface area. So when we talk about building a network of contract pharmacies that would be eligible access points for our sliding fee patients, that was really a big project that we set out to do, especially when there weren't many chains and other pharmacies that were willing to do 340B early on. So this is a picture of the counties that we serve, the service areas the health centers that we have across that service area. And we currently have 75 plus contract pharmacy arrangements, including central fill pharmacies, mail order pharmacies, specialty pharmacies, and so on that we contract with. We do not have in-house pharmacies of our own, and that's why contract pharmacy was so important to us when we set out to do 340B. We needed a mechanism to get access to this program. And we can advance from here. So as Colleen mentioned earlier, the 330 sliding fee current considerations and hot topics of discussion are mentioned on this slide. And I'm not going to weigh in on what's required, what's not required, but I will talk about how our program works, and our program does, I feel, is compliant with a lot of the considerations that are out there and being discussed today. So our sliding fee discounts required to be available at all contract pharmacies. Whether they are or not, we felt early on that was a decision that we wanted to make all of the contract pharmacies that we were able to contract with eligible access points for our sliding fee patients. And then how would we price those? We started off earlier, and we'll talk about how our tiers are created now, but earlier in our evolution we had discounts that were based on percentages of the total amount collected, or what we like to consider the prevailing rate negotiated through the pharmacy benefits manager with those pharmacies. And those discount levels weren't all that deep when we first started. We had more uninsured patients before expansion. We are probably unique because our self-pay population currently is about 5%. We have a lot of underinsured patients, so we'll talk about how our model will address those patients as well. And we also have patients who can't afford their high-cost maintenance drugs and don't qualify for our slide. So we do fund a centralized patient assistance program coordination team, which helps get those patients their high-cost drugs free of charge to the manufacturers as well. And one last point on that last slide, you don't have to go back, but you can see that our contract pharmacy involvement is listed in column 2 on Form 5A, and it has been.
Thank you.
So, okay. And so the early decisions that we'll talk about, I don't mean to repeat myself as we go through this, but these were decisions that I think were very important for us early on that we made. So we elected not to use the 340B price as the discounted price that we're passing along to the patient. And there was a reason for that back then. The reason was that we were under the impression early on, I think most health centers that were getting into 340B at that point were under the impression that the 340B price, and maybe the language was specific to the 340B ceiling price, but we always felt it was the 340B price should not be shared with the pharmacies or other stakeholders in the space. It was our price list, and we were to keep that somewhat confidential. So we built our discount program off of the price that the pharmacy would be reimbursed without it being 340B. So we keep sliding fee contemplation of pricing separate from the 340B pricing, and that was an early decision. We wanted to also be able to record the difference between the discounted amount that we were able to charge or provide to the patient and what the patient would pay if the pharmacy was not participating in 340B. So whether it's the usual and customary price at the pharmacy, or in our case, when we did sign on with a PBM that we'll talk about, that negotiated rate that they were starting at was lower. So if we discounted off of that, then even if we were getting a percentage discount, it then was lower than discounting off of usual customary. But the reporting was the important part. We wanted to make sure that the patient understood what the benefit was that they were getting due to our sliding fee program involvement and their eligibility for our slide. We also wanted to make sure that we were in charge of the eligibility verification and making sure who was eligible, not the pharmacy, not another vendor in the space. We wanted to be in total control of that. We also wanted to make sure there was equal access and equal discounts and everything was uniform across all of the contract pharmacies that we were going to end up being able to contract with. So those are early decisions. So we wanted to see how did we make that happen. So I mentioned, and Colleen mentioned that there's language in the Health Center Compliance Manual that talks about discounting off the prevailing rate or making sure that the patient is not denied services due to their inability to pay. There are other pieces that I've snipped out of the manual here that really did come into consideration with the way that we structured our model. And I think it's important, it was important for us to understand that I do like the idea of discounting off of what we consider to be the prevailing rate in the community. I also liked the idea that we were not going to be offering discounts to patients above 200% of poverty guideline, because if they weren't determined to be eligible for our slide and we were offering discounts because we had access to the 340B program, and we had many pharmacies in our communities at the time that weren't participating with us at 340B, it really wouldn't be well received in the communities that we were serving. And I think that that's probably part of the intent of the language when it comes to these considerations on health center compliance. So those are things that we looked at, and we consider other pharmacy services providers, chains, supermarkets, independent pharmacies, as health care providers in our community. So we want to make sure that we do collaborate with them where it's possible. So we offer the ability to contract with us on a sliding fee and 340B to every one of the pharmacies in our community. And in the size of our service area today, there are probably 3 or 4 pharmacies that we don't contract with currently. And it's a large network, but it offers a very, very good network of access points for our sliding fee patients, and also access for us as Hudson Headwaters to the 340B program as well. So let's go forward from here. So one thing that we wanted to consider was, if we didn't have 340B, let's say that wasn't even available to us, how would we structure an ideal sliding fee program if we could afford to do that? So some of the pieces that I've already mentioned, but I want to mention again, is that we want to standardize the eligibility verification and enrollment for the sliding fee discount schedule that the patients were eligible for. Our board-approved policies, our verification process, all of that, should be centralized and handled through our network and then rolled out across the pharmacies that we can contract with. And the reason that that's an important one is because the network that we initially had access to started with 2 pharmacies, and then it evolved as other pharmacies became interested in doing 340B. Along with that evolution came complexities introduced by the different pharmacies, their vendors that they were either exclusive with, or if they were doing their own programs and they had their own cash pricing. So that's why we wanted to make sure, well, at the time we made a decision which proved to be very valuable, that we wanted to make sure it was consistent across all the pharmacies, so that as we introduced more pharmacies, as we'll talk about, we were able to keep it consistent. So the ability to record the discounts, as I mentioned before, and maintaining total control of the streamlined process. So this is the part where the PBM part that I'll talk about really addressed it. Ease of integration. If a new pharmacy is interested in doing business with us today, and we're able to register them on the OPA database the next eligible period, and they're eligible to go live 3 months after that, the integration process that we've created is really as easy as contacting our PBM with the NADP number of the pharmacy, and it's live, pretty much real time. We remove the stigma around eligibility for the patient. So as a patient goes into the pharmacy, they aren't having to explain to the pharmacist that they're in need of a discount because of their indigent status. The pharmacist doesn't have to make any determination differently at the point of sale. Everything gets adjudicated like it would if it were an insurance program. And then the ability to apply adjustments nimbly and uniformly across a very complex network is very, very important, because annually, as our board-approved sliding fee tiers change, or the policies change, or we want to give deeper discounts, we can do it very, very, very seamlessly. So this is where the consideration is made. We identified in our mind how we wanted to have a program work, and then 340B, is something that we want to contemplate. How would that help us subsidize this? And that's where they intersect. As Colleen, mentioned and explained very, very clearly earlier, is that the 340B program has its own requirements and eligibility requirements. The 330 sliding fee requirements don't always coincide, and the requirements and expectations of a FQHC to provide discounts doesn't often, dovetail exactly with 340B, especially as you get into different business rules and things with the multiple contract pharmacies. But we do want to make sure that 340B program revenue subsidizes as much as we can of the model that we were going to create. So this is where the complexity was introduced into the process. When we started to get interest from pharmacy chains, they oftentimes had their own proposed discount programs or cash price programs that would come along with their vendor, and it was usually based on the entity's 340B pricing or the access to that pricing. Many of the 340B processors or third-party administrators in the pharmacies had very, very different cash programs. Some were the lesser of, some were their usual and customary. There were all sorts of different items that were introduced into the process. Oftentimes the pharmacy, and it could be an independent pharmacy that had their ideas of how to determine eligibility for the discount at the point of sale. It could be the pharmacy chain or their vendor that was going to determine eligibility for the slide that wasn't necessarily consistent with the 330 requirements, and that would present a problem as well. And then are the discounts given to all cash patients and those above 200% of poverty level and so on. So, what happens, when the 340B arrangement only includes brand drugs and started to become more and more popular as our network grew? If we're using 340B as the pricing methodology to pass along to the patient, then we, without an in-house pharmacy, would only be discounting the brand drugs. So that was not in any way what we wanted to do. We wanted to be able to provide discounts to all patients and all patients eligible for the slide, and all prescriptions that they were getting that were eligible from our prescribers, brand and generic. So reaching more patients, with more comprehensive pharmacy services really is in alignment with what the 340B revenue can support, as Colleen mentioned. Anything that's consistent with our mission. So comprehensive services in general, but pharmacy is definitely one that we wanted to use 340B benefit to help subsidize. So the eligibility for 340B and the eligibility for the sliding fee in the contract pharmacies may differ. And what I mean by that, and health centers will say, well, aren't all my sliding fee patients eligible for 340B? By definition, yes, but by business rules associated with individual and unique contract pharmacy arrangements, the actual prescription may not be eligible because of the brand only or profitability filters or lower of methodologies that are in the pharmacy. So those are some of the things that we want to make sure that we were identifying. But 340B can definitely and should subsidize a good portion of the sliding fee scale, and the financial impact of this really needs to be anticipated as you assess it before you put it in action. So how are we going to keep control with the entity? So the integration here, as we thought through, and some of this I've mentioned, but I think that the part that really was important to us it was like a light bulb went off when we started to think about this. How could we integrate this into the pharmacy consistent with how they process other insurance plans, even though this isn't insurance, but could it integrate seamlessly into a contract pharmacy model and be processed in the same way? And the PBM was how we did this, because it's like putting a round peg in a round hole. And I think what some of the struggles are for many health centers, and again, each one of us are different, is that we try sometimes to look at the 340B program or how we're currently offering that and trying to replicate that across multiple pharmacies. And I know that the feedback that we received from some is that it's impossible, it can't be done. And I want to say that we have been able to do it because, we are somewhat unique and we do have some resources based on our payer mix, but it's the mechanism and the delivery model here that I want people to kind of understand, is that if you can use something that's already in place and works very well across multiple pharmacies, and you drive the business rules behind that as far as your sliding fee scale, tiers, and discounts, that's how it really did work very well for us, and it currently does. And it has been for, I would say, the last 16 years. So how does the PBM make this work? The PBM will take data from us based on eligibility. So let's say I was starting from scratch tomorrow. We would take our initial file of eligible sliding fee patients with a crosswalk to say level A is this much of a discount, level E is this much of a discount, and so on. And that would be uploaded to the PBM. The PBM would then send the welcome letters based on the language that we provide to them to educate the patient on what the discount tiers are, where their services are available to them, the network of pharmacies that we have, and then we list the pharmacies that are within our network. All pharmacies that are contracting with us through 340B are the network pharmacies that we use. Even though 340B is not driving the price, we want to make sure that the patients are going to a contract pharmacy that's working with us on the 340B side, because these will be recognized at the pharmacy as commercial claims. That being said, the commercial claim that we're processing through the pharmacy, if it's a generic claim, depending on the business rule of the pharmacy, it may not go through 340B on the back end, but if it's a brand drug, it may come back to us and offset some of the costs that we're providing in discounts. So we want to make sure we use the network that we set up as our network for our sliding fee program. So the other question that usually comes up at that point, and we can stay on this slide, is that the PBM, and we can go back. I mean, we can stay on the slide that you would advance to. I didn't mean to complicate that. When a sliding fee patient is determined to be eligible, let's say right now, they come into our health center and they've gone through, they've submitted their paperwork, and income and family size puts them at a certain slide tier, and they need a prescription right away. that information gets uploaded via email or electronic upload to the PBM, and that patient will be eligible to go to any one of the pharmacies as soon as that information is received at the PBM. So it is, and early on it wasn't as streamlined, but it is a pretty much real-time process. So by the time they leave our facility where they've gotten enrolled and they go to one of our pharmacies, they will be eligible, and that will be processed accordingly. So I'm going to go back to the round peg and the round hole. Is that let the PBM work for you, and enroll the patients through the network and share the eligibility with the PBM. The federal poverty guideline limits and levels are translated into discount tiers. We use letters like most health centers, so that if we want to change the discount from a percentage to a flat fee, we can do that because the letters don't change, but we can crosswalk those discounts to the PBM on the back end. This is the sliding fee scale that we use, and you'll see pharmacy with the asterisk at the bottom, or the third one up from the bottom. We actually slide down to a zero copay, and I do think that some health centers probably can't afford to do that. We are very fortunate that we can. We did evolve into this, so it's still a fraction of total expense that we give in sliding fee to the amount of 340B benefit that we bring in across this complex network. We also have a stop loss or a maximum amount that we'll give automatically on the discount. So a high-cost drug that would provide a discount to the patient of greater than $350 will have to go through either prior authorization, or that patient will be sent back to a coordinator to get their drugs looked at to see if they're available through a patient assistance program. And these are the cards. I did, the question came up on the side. I'd be happy to share the PBM that we use. We use it's a regional PBM that works with a national PBM, but the name of the PBM that we use is ProAct. They're actually owned by a pharmacy chain in the Northeast called Kinney Drugs, but regardless of the PBM that you use, so we have no affiliation other than they have been a great partner for us. But it's the concept, and what you want to talk to a PBM about if you choose to go this route is can they implement and offer the discounts or the pricing that you would like to have offered across a very complex network. And some PBMs may be able to capture 340 pricing and pass that along to your patients if that's what you choose to do. We've chosen not to, and our PBM does not capture and store 340B pricing. So we're working off of their negotiated rate with the pharmacies. So you can see that we have our own BIN PCN number, just like an insurance plan. That's how it gets adjudicated through the pharmacy and through the switch. Okay, so as Colleen pointed out in the chat box, they're part of a national network. So that our PBM that we use, even though it's what I consider regional, they're a national PBM and it works nationally at any pharmacy. So the key considerations when we went into this is that the integration across an entire service area. We use our partner pharmacies. We want to make sure that the affordability for the patients is there, but also it's affordable for us to do this. I will say this, that even though we offer free drugs to the majority of the patients that qualify, it's about 83% of the total expense of what we put through goes through that tier 1 generics, and it's not as much of an expense as you might think. So you really have to financially do the analysis up front and look at your patient population. And I know that there are health centers that have a very, very high percentage of uninsured and undocumented patients. So this may not be a model that will work very well across all of your contract pharmacies for you if the expense is too high. But you can dial in those discount tiers to make sure that there is affordability, and it has worked across other FQHCs pretty well as well. We also wanted to just make sure that we considered the 330 program intent, collaboration with providers in the community. That being said, no discounts to patients above 200% of poverty level. We do offer other ways to help people get affordable medications that may be above 200% of poverty level. and that there's no barrier for care. So our lowest tier, obviously there's no barrier. It's not even a nominal fee, but you can apply different fees to this type of a model and still have it integrate into a very, very diverse pharmacy network. So with that being said, I'm sure that there are many questions that come up, and every time that we present this model, there are multiple questions. But I want to just reiterate the intent. The intent is if you can take anything from this presentation that may help you wrap your mind around a model that could be integrated into a multiple contract pharmacy situation, if that's what you choose to do, and do the financial analysis up front and see what you can offset with 340B benefit, it may simplify things for your organization and for your patients. So I'm going to take a quick look at the chat box here and see if there's any questions that I didn't answer.
Sure, and I can actually read some of them out to you, if that would help, Jim.
Sure.
One of them is, does a retail pharmacy have to run commercial or private insurance prior to applying the sliding fee discount?
Yes. So if a patient has other insurance and they are also eligible for our sliding fee discount, this will act as secondary insurance. So the secondary payment amount, if their copay is extremely high, but the copay amount is higher than the sliding fee amount, they will never pay more than they would pay if they didn't have other coverage as that secondary out-of-pocket expense.
Got it. Okay, do all PBMs participate with you or just a few?
Well, when you say do all PBMs participate with us, we participate with this PBM. All right, this PBM, has a backbone that is actually a national PBM. So they're using the network of another PBM. And the reason that that's important to understand is that that other PBM has already negotiated contracts across pretty much every pharmacy in the country. So that's why it's so easy to turn on this particular model through the PBM that we use here. So other PBMs can make this work. We currently, as a health center, use this one PBM. As a helping other health centers, they can use any PBM they like. It's not tied to any third-party administrator process. It's really separate from 340B. But it's up to the entity to determine what the network is where they want to apply the sliding fee program.
Okay. How do you balance the idea of no discounts to patients over 200% FPL with the no barrier to care?
Right. So this is probably a question for others in our organization, but the interpretation that I have, and this is my own interpretation, is that requirement is for sliding fee eligible patients of our network. So if they're at 200% of poverty level or lower, then we want to make sure that those patients have no financial barrier for care. Now, other barriers that may come into play are transportation, language, and all the other things, but when it comes to a financial barrier, if patients can't afford their medications, there are other mechanisms that our network actively applies. So, as I mentioned, we use 340B benefit to pay for Pharmacy Assistance Program software. We use a program called RX Assist Plus. But we have a team of people that operate our sliding fee program and the patient assistance program coordination. So if someone's above 200% of poverty level and they can't afford a medication, if it's available through the manufacturers, we'll make sure that they're put into that process and that gets delivered to their health center and handed over, dispensed by a prescriber in that health center that's most accessible to them. There are other mechanisms that we work in the community also to make sure those patients get affordable access to medications. But there's one thing that, over the years, I mean, these are terms that have come up, and I don't, in any way, it's not to be insensitive, but there's the inability to pay and the unwillingness to pay we've run into sometimes. And what I mean by that is that when you have a very robust sliding fee program or discount program at a contract pharmacy especially, You don't want someone who has the means to pay coming to that pharmacy and without proper eligibility verification getting the discounts. So we are very, very, very careful to make sure that we do proper eligibility verification to make sure that the patient does have an inability to pay.
Mm-hmm. Makes sense. Is Walgreens in your contract pharmacy network?
Yes.
Okay.
So
okay.
That's a good question, right? So Walgreens has their own cash program, and there is a lower dispensing fee in most cases for a cash claim versus a commercial claim. This will be recognized as a commercial claim, and we haven't been successful in getting them to recognize our plan as a cash plan and having a lower fee on it. But it will be processed like any other commercial plan. So what happens is that we bypass, for our sliding fee patients who are eligible, those cash plans that the pharmacies may have, and then the patients who are above 200% of poverty level or don't qualify for our slide, they're welcome to use those other cash programs that are available at those pharmacies.
Mm-hmm. Okay, Jim, I'm going to take one question myself, let you take a look if there's any other key ones. Then I wanted Tim to address one quick issue before we wrap up at the top of the hour about Walgreens.
Sure.
The question I see here is it a requirement to have multiple scales for pharmacy? The BIPIC requirement is that if you charge an explicit a professional dispensing fee, if you charge that to what you would typically consider your sliding fee scale patients, your uninsured and underinsured patients below 200% of poverty, if that's an explicit charge, then yes, that is subject to all of the sliding fee scale rules, which means at least 3 levels or whatever the categories between 101 and 200%, and 0 or nominal below 100%. However, BIPIC has been explicit that you are not required to charge a specific professional dispensing fee to those patients. It doesn't have to be something on your fee schedule. They likened it to, like, you don't, sometimes if a doctor calls a patient, you don't bill separately for that. That's considered sort of like a standard cost that's just rolled in with everything else. But if you do have an explicit professional dispensing fee listed on your set of fees, your schedule of fees, then that must be discounted according to the sliding fee scale rules. So, and I'm happy to talk more about that offline because I know it's confusing. But Jim, any other questions? You feel like we're burning questions before we turn this over to Tim for one last thought?
No, I'm happy to turn it over to Tim. I apologize for the slides not being advanced, as seamlessly as possible. But if anyone has questions, my contact information is in those slides. So I'd be happy to answer questions, from how our model works and go from there.
Absolutely. Thank you so much. And it was on our end, the slides didn't advance. One last thing before the top of the hour. Tim, do you want to talk about this email people are getting from Walgreens?
Certainly. This isn't necessarily new. It came up, 6 to 9 months ago. Walgreens let everybody know that they were moving to a different way of addressing 340B surpluses within their pharmacies. And my assumption is that they're going to aggregate. If you have multiple Walgreens pharmacies, they'll aggregate anything that is surplus, and then they inform you of that and send you a check for the difference between the NADAC price and the 340B price. They then put the onus on you to reach out to the manufacturer and say, our contract pharmacy had an overage in this amount. How do you want us to handle this? So the reason I phrased it like that is don't just write a check in that amount directly to Pfizer or SmithKline or to whoever. You will specifically write them a certified letter stating that you've been informed of this and you want guidance from them on how you would go about refunding them this $150 or this $1,000 or this $3,150. One thing you need to look at, you need to ensure that it does not become something that reaches your threshold for a material breach, in which case you have more concerns on your hands. But do not just send them a check in the amount that Walgreens has sent you, but do set that money aside so that in the future when the manufacturer comes to you. And as I learned last year at a conference, it could be a year, 2 years, even 3 years later and say, yes, we want that $31.50 from you. You write that check and pull it from that account. So be sure that you follow up with them.
That is great. Thank you. One last question that just came in from Derek Peel was, are you required to offer our sliding fee discount scale at our contract pharmacies if we have it at our in-house pharmacy? The short answer is please look at the excerpt from the manual that was a handout. We talk about it there, that question. The long answer is there is not a clear dividing line. But the rule is that your uninsured patients, sliding fee patients must have access to affordable medication. So if your in-house pharmacy and your contract pharmacy are pretty close geographically, and it's reasonable to think that a patient could get to your in-house pharmacy if they wanted the discount, then that's okay. But if let's just say they were an hour and a half apart, and at that point, it becomes harder to say that that the person really has access to that discounted fee, because getting to the in-house pharmacy, if that's the only place where that discount is offered, really is not very easy for them. So it depends really on the proximity of the patients to the in-house pharmacy and their ability to get there on their own to really take advantage of the discounted rates offered only there.
Colleen, the other alternative is if they offer a delivery.
Oh, yeah.
Or potentially can mail it to the patient. The idea behind this is we can't inconvenience the patient in receiving a discounted med. So if you have alternative ways of getting that to them, you know, sometimes it's going to be cheaper for you, even if you charge them the $3 for mailing, than it would be for them to try to get it at your contract pharmacy. So you need to look at all of that, but your end goal is to ensure that your patients have access to affordable discounted medication.
And I do have to say to that there is not a place where we are going to find this in writing, okay? And I know that's frustrating, but it's one of those things where we're better off letting the sleeping dog lie. You want to be able to say that you fulfilled your responsibility to make affordable medications accessible to all of your patients. If we go back to HRSA and ask them for clarification on this question, I'm afraid we're not going to like the answer. And that's why we're not going out asking for an explicit answer on this. But I would once again go back to the spirit of the law. Can your patients, do they have access to that discounted medication? So with that, thank you, everybody. Oh, and I just see something here about somebody okay, Jason, I'll follow up with you about the OSV reviewers. We do have a few OSV reviewers who are going a little overboard on their review of contract pharmacies. If you're experiencing that, let me or Feldsman Tucker or somebody know. But at any rate, with that, we're going to wrap it up. Thank you, everybody. Please do the 1-minute survey. Have wonderful holidays, and we look forward to talking to you next month. And thank you, Jim, Tim, Sue, and everybody else. Jason, Petra.